Hi, in this video I'm going to show part of the management of a rather complicated case. Sometimes when there's been complicated ocular surface reconstruction, you have to go back and check what's going on. 1 month after a very difficult Paul Glaucoma implant insertion in a one-eyed patient with severe primary angle closure. The conjunctiva dehisced with both plate and tube exposed. On revision, I covered this with a complete donor cornea cut into 2 pieces to fit, plus a large amniotic membrane graft. Post-operatively, it was almost impossible to assess progress because of the patient's extremely tight eyelids and orbit. The surface seemed to be healing adequately, but 1 month after the revision, I still could not see the area over the plate. Six weeks after revision, I therefore took the patient back to the operating theatre to examine the wound over the plate. The conjunctival edges at the superior and inferior margins of the graft seemed to be healing as expected. Despite general anaesthesia, it was still very difficult to see the posterior wound edge, though the plate seemed covered. However, the 2 segments of the donor corneal patch have drifted apart, leaving a gutter in between. While the edges seem to have healed with the tube and plate well covered, part of the proline ripcord is exposed. The external loop of the proline ripcord can be seen here to be only partially covered. Reassuringly, there was no evidence of aqueous leakage from the area of the plate. In order to cover the proline and prevent tube erosion, I sutured the 2 corneal segments together with 10-0 nylon. Although the limbal edge seemed to be healing well, I added 2 further sutures to ensure that the graft edges were secure. Just under 4 weeks later, the eye was only marginally easier to examine, but all of the edges appeared to be healing well. This is the appearance after suture removal. Thank you very much for watching. Watch this space for the full story later.